Good evening, everyone. Welcome to our Digital Infoday Session. This webinar will cover an overview of what AL amyloidosis is and the treatments on offer. But first, a little bit of housekeeping. The webinar is being recorded and will be available to watch on our website and Facebook. If during the webinar you'd like to chat to each other, you can use the chat box. And if you have questions for the speaker, please use the Q&A box. Hi, I'm Suzanne, and I'm the Head of Clinical Practice Services at Myeloma UK. As you know, we're a patient-focused organisation, and we aim to empower, inform, and support patients in everything that we do. The majority of my work involves working with doctors and nurses to help make this happen. As an organisation, we rely on the generosity and kindness of our supporters. Myeloma UK receives no core government funding, so your support is vital and we are truly thankful for all your contributions. I'd like to welcome this evening's expert from the National Amyloidosis Centre in London. We're joined by Professor Ashutosh Wichalekar. Ashu also leads the Myeloma UK AL amyloidosis working group, which has been set up to address the barriers to diagnosis. And hopefully at a future event, we can update you on our progress. Ashu, thank you for talking to us this evening. I'll now hand over to you to start your presentation.
Thank you. Thank you, Suzanne. It's a pleasure to be here this evening for the webinar. And we'll have an overview on systemic AL amyloidosis. We'll begin with a bit of background on what is amyloid, and then we'll move on to how do you diagnose it, how do you monitor it, what are the various treatment choices, and then we'll have options for you to ask questions as we go through. So the talk will cover what amyloid is. We can see how it affects enrollment systems, and then we'll go through its treatment and management of some of the symptoms. So what is AL amyloidosis? It is a disease of protein buildup. This happens because abnormal cells in the bone marrow called plasma cells produce immunoglobulin antibodies. Light chains are a part of normal immunoglobulins produced by healthy plasma cells. In patients with systemic amyloidosis, there are abnormal plasma cells which produce abnormal immunoglobulins, which really have no function. They circulate in the blood, but they also produce excess of these little bits of protein called as light chains. These light chains in amyloidosis tend to be unstable, and therefore they will misfold. When a protein misfolds, it exposes little sticky bits which are inside the protein. These will stick, form amyloid fibrils, and deposit into different organs and different tissues. And these deposits are then incredibly difficult for the body to clear. So they remain in position for a very long time and lead to problems with the functioning of the organ wherever the amyloid has deposited. Within the UK, amyloidosis, well, also globally, still remains a fairly rare disease. We think there are about 500 to 600 new patients with AL amyloidosis diagnosed in the UK. We see quite a large proportion of these patients come to the National Amyloidosis Centre for assessment. Since the fibrils in amyloid have got propensity for sticking to different organs, the amyloid pattern of every patient may be different. The light chains and amyloid deposits will target one or more organs, and what symptoms you get depend on which organs are affected, how badly they're affected, and the combination and how early or late the diagnosis was made. Where can amyloid deposits occur? The protein that is produced in the bone marrow. So the abnormal protein circulates in the bloodstream. And therefore, the amyloid protein can affect essentially any organ where the blood can flow. But the three common organs affected are the heart, the kidneys, and the liver. In about 1 in 5 patients, the amyloid deposits build up in soft tissues, such as the tongue, causing enlargement of the tongue. And in about 1 in 10 patients, it will affect the peripheral nerves. And in a significant number of patients, it will affect the autonomic nerves. These are the nerves which supply your blood vessels and your gut, so it can cause low blood pressures and problems with diarrhea. And we'll come to these various organs and what happens when amyloid affects these organs in a bit more detail as we go through the talk. Amyloid is a tricky diagnosis. The symptoms can be quite subtle. To begin with, there may be a little bit of swelling on the feet, breathlessness on exertion, maybe while climbing stairs, some bruising, occasional diarrhea, sometimes dizziness when standing up. And these symptoms will continue to progress depending on which organs are involved. And over time, one or more symptoms become dominant, typically breathlessness, swelling on their feet, dizziness, diarrhea, and autonomic neuropathy, and then swollen tongue if the amyloid buildup is within the tongue, and peripheral neuropathy, tingling, and numbness. At this point, the patients are usually referred on to various specialists and the diagnosis will be made when either somebody recognizes that there is a combination of organs involved or tissue biopsies undertaken. The complications are really dependent on how badly the various organs affected, and heart and kidneys are the two most common organs affected by amyloid deposits, and therefore we very commonly see patients with damage to their heart causing cardiac dysfunction, or damage to the kidneys causing the kidneys to become leaky to protein or having a degree of dysfunction of the kidneys. The protein deposits in the heart make it very stiff. You can think about amyloid as a bit like pouring wax into the heart. Originally, the term amyloid was used because they thought it was like starch. It looked a bit like potato starch when they looked at it in organs which they had reviewed many hundred years ago. The heart becomes stiff and enlarged, and because it is stiff, it can't pump the blood that well. It cannot fill the blood that well. We diagnose amyloid in the heart by looking for abnormal biomarkers. Some of you may have had a test called NT-proBNP, which is a marker of heart dysfunction, and it goes up in amyloidosis. We do echocardiograms, which shows the stiffness of the heart, and then we do cardiac MRI scans, which will show a very typical pattern in amyloid. Because the heart can't pump fluid as efficiently, there is accumulation of fluid. It can be in the legs or the abdomen, or it can be in the lungs, leading to shortness of breath. The protein in the heart can lead to the heart becoming a little bit irritable, and you can get irregular heart rhythms. Sometimes these are minor, sometimes they can cause quite a serious problem. Because the heart is not very efficient in pumping the blood pressure starts to go a bit on the low side and can drop quite a lot. And since the muscles are being starved of their blood, fatigue becomes a big symptom of cardiac amyloidosis. In the kidneys, the deposits will stick in the filtering bits of the kidneys, and in sort of very simplistic terms, they'll clog up the kidneys' filtering elements and damage them, make the kidneys leaky to protein, and stop the kidneys from functioning. So the kidneys are unable to maintain a normal salt and fluid balance. They leak a normal protein called albumin, and we diagnose renal amyloidosis based on blood tests, which tell us that the kidney function may be abnormal. There is low serum albumin. The urine can be very frothy, and that's a symptom that you might have noticed for those of you who have had renal amyloidosis. And we do serum amyloid PEA scintigraphy at the amyloid center, the SAP scan, which tells us that there is amyloid in the kidneys. Some of the symptoms of renal amyloid will overlap those of cardiac amyloid, such as fatigue, fluid retention, loss of appetite, gain in weight. Blood in the urine can occur, but is quite an uncommon symptom in amyloid. And for us, it's often a symptom that something else may be going on. Frothy urine is very common. And then when kidney function starts to be more impaired, it can affect the hemoglobin production, lead to anemia, loss of appetite, itching on the skin, and other symptoms. Amyloid is typically diagnosed when you have been to a specialist who can suspect amyloidosis based on the presenting symptoms. The blood test will often reveal markers of cardiac dysfunction, liver dysfunction, kidney dysfunction. An abnormal protein may be detected, and then a diagnostic test is made. More often than not, this is a biopsy of the affected organ, which may be the kidney or the liver. But if the heart is diagnosed to have amyloid based on echo or a cardiac MRI scan, the diagnosis is made that way. Patients are then referred to us at the amyloid center, and you may have undergone this so-called SAP scan, where we inject radio-labeled SAP, which is very good for showing amyloid in the liver, spleen, and kidneys. Once the diagnosis has been made based on either a biopsy or a scan, which may be the SAP scan or a heart scan, you will have had a number of blood tests which will look for heart markers such as troponin, NT-proBNP, tests of liver and kidney function. We'll measure the serum for free light chains. These are the little abnormal protein bits that I showed you earlier. And you will have urine collection for 24-hour proteinuria to see how leaky the kidneys are to protein. Some of these tests, such as the blood test, the light chains, urine protein, are done at regular intervals to assess how things are going on during the disease and during the treatment, as is also true of the echo, MRI, and SAP scan. We don't keep repeating biopsies because they are not very accurate for tracking amyloidosis. So what happens after the diagnosis is made? The key to remember is that amyloidosis is a treatable disease, and therefore it's important to make the diagnosis early and seek treatment early. Majority of the patients do respond to treatment. And most of the current treatment strategies are chemotherapy strategies, which are aimed at killing off the bad plasma cells in the bone marrow to reduce the amyloid-forming light chains. It's not yet a curable disease. We can't get rid of it forever. And the drugs that we use as yet don't help us to dissolve the protein deposits that are there in the body. So we can stop them from building up, put patients into remission with the hope that we'll stop the buildup of the deposits, depending on how well you've responded to treatment, with the expectation that over time, the body will clear deposits on its own, which it always does. Once you've had treatment, you will be in remission for a period of time, which can be months to years. But the plasma cells can creep back on, a so-called relapse requiring more treatment. And therefore, it follows what's called as a relapsing remitting pattern. You have a treatment, you have a relapse, and then it may come back. So when patients are initially diagnosed, the light chains are quite high. There are lots of symptoms. This is when you would receive chemotherapy treatment at new diagnosis. The light chains will drop after treatment, and we expect and hope that they will drop quite rapidly, which is the faster they drop, the quicker we'll stop the buildup. Then you're in a remission period where the light chains are nice and low. This is when the symptoms of amyloid are stable or hopefully getting better as the body is clearing these amyloid deposits. And this period here, which is the remission period, might last quite a long time in some people. And we've had patients who've gone on for 5, 6, 7, 8 years after chemotherapy without requiring further treatment. But there are others where this period may be short and last only a few months. And that depends a little bit on the nature of the abnormal cells in the bone marrow. The light chains will then start to creep back up, and at some point we'll treat. Now, this graph seems to suggest that when they're back to where they were at the beginning, we'll treat you. But generally, now we realize that if we wait this long, the amyloid deposits will start causing damage again. And as soon as we see that they're going up, we won't wait till they reach here. We'll probably start your treatment as soon as they've reached, as soon as we know that the graph is climbing and eventually they'll reach a higher level. Refractory disease is uncommon these days, but this is disease where we are struggling to control the light chains. We have got a number of treatment choices, and we can usually move on to a different type of treatment to control the disease if the first treatment hasn't worked that well. We've got a break. I'll hand over to Suzanne now for questions.
Thanks, Ashu. That was a very comprehensive overview. So thank you to everyone who's submitted questions. So first of all, we have a question from Janine. Has there been any recent research on the potential cause of AL amyloidosis?
There has been quite a bit of research to figure out why the plasma cells become abnormal, but I don't think we've got an answer to that. And the only cause that is so far known is exposure to radiation in very high levels. These are things like a nuclear reactor accident, but generally the cause still remains unclear. The feeling is that the plasma cells in the bone marrow are undergoing rearrangement of their DNA, because every single time you encounter a new infection, the plasma cells will produce an antibody. So they rearrange their DNA to produce a specific antibody sequence, and this happens millions of times. Something goes wrong when this rearrangement is happening, and we don't really know the cause of why it goes wrong. And it may either be just a chance, or it may be that there is a genuine defect in DNA repair, or there is a particular environmental factor which has triggered this damage.
Thank you. So our next question is, what is the average time that patients stay in full remission? Is there an average? And in your experience, what has been the shortest and longest time?
That's a good question. Is there an average? We use what we call as a median, which means that if you line up all the patients, where is the 50% time point where half the patients would have relapsed and half wouldn't have relapsed? It depends a little bit on how deep the response is. So if the patients who get normalization of their light chains, we find that the median time, which means that by which time 50% of patients would have relapsed and 50% would not have relapsed, is about 3.5 years. What is the shortest time? Unfortunately, we have seen patients whose light chains go up within a month or two of stopping treatment. So it can sometimes go up quite quickly. So we have to continue monitoring, which is really important. And what's the longest time? That is a tricky one. But I do remember a patient who we had a consultation with in clinic just this morning, who was treated in 1997 and who has not yet relapsed. So that just gives you a flavor for how long someone could stay in remission. But that is the exception rather than the rule.
Okay, that's great. Thank you. So the third question is, do we know why some patients' disease responds to treatment less than others?
We don't know that very well, but we are starting to understand. We and others have looked at the genetics of the plasma cells, and these plasma cells have a number of genetic abnormalities. And what we realize is that certain genetic abnormalities confer resistance to the treatments that we can give. And therefore, some patients' disease will respond better than others, or sometimes the plasma cells will creep back on quicker than others. So we believe the answer lies in what the genetic makeup is. And we hope that in the next few years, we'll be able to figure out, based on genomic sequencing, who will respond to which treatment and who will have shorter and longer remission durations, but we are not quite there yet.
Okay, thank you. Our next question also involves genetics. So the next one is, are AL amyloidosis, myeloma, and MGUS genetically linked?
There are two ways of answering this question. I don't know what the intention of the question was. They are not hereditary, if that's what you meant. They don't run in families. But if you were to analyze the genes of a plasma cell from a patient with myeloma, with MGUS, and with AL, the genetic changes are very, very similar. And if I was blindly presented with an abnormal genetic panel from any of these three diseases, then it would be very hard to say whether this was from an amyloid, MGUS, or a myeloma patient. But myeloma patients tend to have many more abnormalities, and they also tend to have many more abnormalities which cause the disease to have slightly more aggressive character than MGUS and amyloid. So amyloid and MGUS tend to be much closer together than myeloma per se.
Okay, thank you. And we've got a question here from David. If you have cardiac AL amyloidosis and have been told it's too risky to have a stem cell transplant, is there any chance this would change in the future, for example, if remission was good?
Absolutely. We have shown very nicely that the heart does get better over time and things improve. And patients who are not suitable for a stem cell transplant at diagnosis, after a year or two, the heart can improve well enough for them to have diagnosis. And we've certainly transplanted quite a number of patients within our clinical practice at UCH who presented with cardiac amyloid where we thought they were not suitable for transplants, but 18 months to 2 years after the diagnosis, they did become suitable for transplants.
That's great. And then that's very optimistic for patients to hear. I'm going to see if I think we've got some questions on our chat. Yes, we have. So this is from Ross. What is the gold standard treatment today for cardiac amyloidosis? And what is the next big thing for this condition? And he gives us thanks.
So I think we've got the treatment coming further down. Suzanne, so if we may come to the treatment question again after we have discussed the treatment choices. So Ross, we'll come back to your question. You're muted. Suzanne, you're muted.
Sorry, I think there's been some feedback, so I'm getting muted and unmuted in the background. So thank you, Ashley, for answering those questions. So we'll now continue with the second part of the presentation on treatments.
Thank you. So the aims of treatment in amyloidosis are to control organ damage, prolong life, improve quality of life, and the treatment itself has to be balanced based on the risks of the chemotherapy and the benefit that it offers. Because amyloid has damaged various organs, there will always be side effects from treatment. And therefore, we have to manage these side effects by dose adjusting the drugs, yet at the same time give enough treatment so that we can control the disease and then reduce the symptoms and reduce the light chain. So it's a bit of a balancing act when we're treating amyloidosis. And the standard treatment protocols that we use often end up being modified quite a lot to suit each individual patient. So the treatment is usually chemotherapy that will control the underlying light chains and prevent new deposits from forming. Supportive care is absolutely critical to manage the side effects and the symptoms both from the disease and the treatment. The choice of the first line treatment depends a little bit on the extent of organ involvement and where we think you're going in terms of whether there may be a transplant involved or what drugs are available. And currently, at least here in the UK, all the drugs that we use are approved for amyloidosis, although this has changed. As of a month ago, we said there were no approved treatments for AL, and that's now quite different. And then we often have clinical trials that you may be offered if there was one available for you. So patients who present with limited organ amyloid, such as very early kidney amyloid or some soft tissue amyloid, and who are otherwise fit, one potential treatment is an upfront stem cell transplant or high-dose treatment. For majority of the patients, and this will include about 75% of patients with amyloidosis, the standard treatment is chemotherapy, combination chemotherapy using 2 or 3 different drugs. There is an overlap. Patients who have chemotherapy could go on to have a transplant. Patients who have a transplant and don't respond can have chemotherapy. But as we've gone through our treatment algorithms, we are more and more realizing that having some initial chemotherapy before a stem cell transplant allows the transplant to offer even greater benefits. So certainly within the UK, our practice has now changed. We would very rarely do a transplant without offering upfront chemotherapy. So almost all patients will get some form of chemotherapy, ensure that the disease is a response, and then you go into a stem cell transplant if eligible, or complete the chemotherapy if not. And then we have got access to clinical trials, which will have either a study of new drugs that will control the plasma cell disorder, or sometimes agents which will help us to remove the amyloid protein, and that goes along with supportive care. So what are the initial treatments? Our standard frontline treatment is based around a drug called bortezomib or Velcade, which those of you who have had chemotherapy may have had for amyloid treatment, typically combined with a drug called cyclophosphamide and some steroids. We also use these other treatments, lenalidomide for patients who have got nerve damage where we can't use Velcade. Thalidomide was one of our standard treatments, but we find that it's not as effective and a little bit more toxic, so we don't use that. And then oral melphalan along with dexamethasone is a very easy oral treatment, which we sometimes use where we think Velcade may not be suitable, or for other reasons where we don't want the patients to come to hospital that frequently. But there has been one big change in the new treatment for amyloidosis, daratumumab. Some of you read the news would have seen that this is a monoclonal antibody directed against plasma cells. And when this is combined with bortezomib, cyclophosphamide, and dexamethasone, it's significantly better than compared to VCD or Velcade cyclodex alone. And as of last month, this has been licensed in the US as the first-line treatment of patients with AL amyloidosis, and is undergoing assessment in the UK and Europe for approval as frontline treatment. We are hopeful that once it's been approved, we'll have funding to start using this as first-line treatment for our patients. And this is certainly something in the pipeline. At the moment, we're using daratumumab for patients who have relapsed after frontline therapy. Stem cell transplantation is used in maybe about 10% of patients would be suitable, but within the UK, maybe 3 or 4% of patients actually get a stem cell transplant because other treatments like Velcade are very effective. And the way stem cell transplant is done is patients get either an induction chemotherapy or some growth factors, which act on the bone marrow to stimulate these stem cells, which are within the marrow, to come out into the blood. You're then put on a machine, which is a bit like a dialysis machine, where the blood is taken out, spun around, and stem cells are collected, harvested, and then we can store them for quite a long time. Then you're admitted for the transplant itself, where a big dose of melphalan, which is the chemotherapy to kill the bad cells, is given. As a corollary, it will kill the good cells. Typically, a day later, the stem cells are given back as a drip. They'll then find their way back into the bone marrow and make a new bone marrow. Within this period between where this melphalan is given and the stem cells come back, there is a risk of infections and other problems, and therefore we have to be very selective of who goes in and gets a transplant. Patients where the first-line treatment works and stay in remission will continue to follow them, but when the disease relapses and the light chains start to creep back, as you saw in the graph, we would go on to get a second-line treatment with something else. Now, the choices are quite a lot. We could either use the same treatment if the response had lasted for many months or many years, we could add something to the treatment, or we could change over to something else. Certainly here in England and most of the UK, treatment algorithms are dictated by drugs that NICE, which is the National Institute for Clinical Excellence, has approved for treatment of myeloma, and we certainly use drugs under the umbrella of multiple myeloma. And we would generally follow the algorithm that NICE dictates for myeloma treatment, which somewhat limits our options in terms of choices of therapy at different levels. If someone's organ function is not very good, particularly kidney function, then there may be candidates for kidney transplantation if they're otherwise suitable. We would often consider a stem cell transplant or some other form of chemotherapy to control the light chain levels before an organ transplant is done. And then, again, if there is a clinical trial of a new agent, then we'll certainly be able to offer that clinical trial if it is available. Within the UK, or certainly in England, the options at relapse for patients have been treated with first-line Velcade and the light chains come back. Under the myeloma umbrella, we use daratumumab with Velcade and Dex. We have the option of using other drugs such as lenalidomide or carfilzomib, but these are used in selected patients where we can't use this particular combination. Patients who relapse further again, the options are then to use lenalidomide because this drug wasn't used for the first 2 lines of treatment. And again, it can be combined with this oral Velcade-like drug called ixazomib with or without dexamethasone. If it keeps coming back again, we've got more choices further down the line. We've got the option for using daratumumab alone if it wasn't used before. Or for patients who have responded to DARA in the past or not had DARA in the past, we can use this combination of isatuximab, pomalidomide, and Dex, which has recently been approved by NICE for myeloma relapse, where isatuximab is not suitable because DARA wasn't working. Then pomalidomide, Dex is another option, which is an improved version of lenalidomide. And I think this has just been repeated, DARA monotherapy. And then 4th line and beyond, we've got the option of using Velcade in combination with a drug called panabinostat. And we often have other drugs which are available on clinical trials that we might be able to offer if the disease keeps coming back. We find that there are smaller and smaller number of patients who go because with every relapse, the time that you stay in remission appears to be very similar to the first response in amyloid and can be often quite prolonged, as every treatment has got an equal chance of working and for equal length of time. One of the key problems with amyloid is to manage side effects of treatment. One of the biggest side effects we find is fluid retention because most patients have heart or kidney involvement. Steroids, which are an integral part of the treatment, which we all dislike so much, tend to cause a lot of fluid retention, and managing fluid retention is one of the key aspects of managing patients with amyloidosis during chemotherapy. The heart has protein deposits in it, it's quite irritable, and irregular heart rhythms can occur, and we need to monitor it very carefully. Patients often have kidney, which may not be completely normal, and we have to ensure that the drugs we give don't impair the kidney function. The diuretics we give can affect the kidney function, the heart can affect the kidney function, and we have to manage this as we go through the treatment. Neuropathy may be a feature of amyloid, but can also be a side effect of some of the drugs, such as Velcade, and therefore we have to monitor for this and assess neuropathy as we are going along. Nutrition and weight loss. This is a problem which is quite common in amyloid patients, as the protein may have affected the autonomic nerves which supply the gut. The heart may not be functioning too well, the kidneys may not be functioning too well, which leads to loss of appetite. And we make that a lot worse by giving chemotherapy, which makes you feel a bit rubbish, changes the taste, appetite may vary. So we do have to focus a lot on nutrition. And weight is very tricky because a lot of the weight in amyloid patients may be fluid related. And sometimes you might think that you're actually gaining weight, whereas you're losing flesh weight and gaining fluid weight. And therefore we do focus quite a lot on nutrition, and we try and get dietitians involved very early during the treatment. We monitor blood counts because various chemotherapy agents can affect the blood counts. And patients who have got irregular heart rhythms or leaky kidneys have a risk of blood clots and may need anticoagulants. And certainly some of the drugs we use can also increase the risk of getting thrombosis in the veins, and we have to monitor for that. It's really important that if you are getting any of the different side effects, you bring them to the attention of the team who is treating you so that they're treated early. If caught and treated early, then they're much easier to manage than if you let them go off for too long. You will have a whole cocktail of drugs when you start chemotherapy, typically some antibiotics for infections, antivirals to prevent shingles. If you're at a risk of blood clots, then you may be on blood thinners, which have to be closely monitored. During early part of the treatment, we often admit patients for monitoring their heart rhythm, or they are on drugs which help to stabilize the heart rhythm. If you're anemic or the white cells are low, then you will get injections of growth factors. You're often on diuretic water tablets to help manage the fluid overload, and these have to be adjusted often on a day-to-day basis. And certainly a lot of patients who come to my clinics, we teach them how to adjust their diuretics because that makes things much easier for them. We are rigorous in getting you to monitor your weight every day, monitor your blood pressure every day. When you come to clinic, we'll check your kidney function. Fluid balance is absolutely critical. You have to drink enough, but not too much. So we would generally say restrict your fluid intake between 1.5 to 2 liters every day. If you drink more than 2 liters, you're likely to accumulate fluid. If you drink less than 1.5 liters, your kidneys will not be very happy, your blood pressure will drop, and your kidney function will become abnormal. As we talked about nutrition a bit, food supplement and referral to dietitians are absolutely crucial to ensure that we can maintain adequate nutrition during treatment. Where is the treatment for amyloidosis headed? 2 directions: controlling the plasma cells better, and more critically important, getting rid of the deposits which are causing the problems. So in terms of controlling the plasma cells better, we are moving towards using new agents which have now been approved, some of which have been approved for myeloma treatment. These are newer monoclonal antibodies like daratumumab, but sometimes conjugated with toxins. We've got certain drugs which work when there are certain genetic mutations, and these are very targeted treatments, and we hope that we'll get these in amyloid patients who have got specific mutations, such as an 1114 translocation. And the area that is really of interest to us is the so-called area of active immunotherapy, where we have antibodies which will activate your own immune system to kill the plasma cells, the so-called bispecific antibodies. And we are waiting to see some results in multiple myeloma on the so-called CAR T cells, which are active immune T cells. And we hope that we'll be able to introduce those for patients with amyloidosis to cause longer-term disease control. If we get these therapies and prove that they're effective, we may be doing stem cell transplant a lot less than what we're doing now. And then we come to the other bit, getting rid of the amyloid deposits. Bodies are, for some reasons, incredibly not inefficient in getting rid of the deposits. And if we can help the body to clear the protein deposits, it would certainly help to improve things very quickly. There are 2 drugs which are in clinical trials. One of these drugs is an agent called NEO-001. This was studied some years ago for amyloidosis, and we struggled to show it was effective, but a recent analysis has shown that in patients with cardiac amyloidosis, particularly those with advanced disease, it seemed to show a degree of benefit. And a trial with this agent for newly diagnosed patients is about to start in our center. And there are 2 trials which are opening with this another antibody, which binds to the amyloid protein fibrils and helps the body to clear these fibrils quite soon. This is called as KEL-101. And we're about to start 2 trials, one in patients with moderate cardiac amyloidosis and one in patients with advanced cardiac amyloidosis for newly diagnosed patients who haven't received previous treatment, to see if this drug helps to clear the protein deposits early. In the early phase clinical studies, KEL-101 seemed to show really good responses for patients who were given this drug. But we are a bit cautious because we've had a couple of previous studies with antibodies to clear amyloid deposits, which did not turn out to be positive. So we're keeping our fingers crossed on these 2 trials, but we have got 2 separate trials for newly diagnosed patients. At the moment, we don't have any trials for these agents for relapse, but I'm sure they'll come in the coming years. I think that ends the treatment section. Over to Suzanne again.
Right, thank you. So now we've got some time for more questions. So if we go back to Ross's question, so that was, what is the gold standard treatment today for cardiac amyloidosis, and what is the next big thing for this condition?
So the gold standard treatment at the moment is the one treatment which has actually become licensed for newly diagnosed patients with cardiac amyloidosis, which is a combination of daratumumab with bortezomib, cyclophosphamide, and dexamethasone. We think that would certainly be a very effective treatment for newly diagnosed patients. And for patients where the disease is relapsing, again, patients who have not had daratumumab, a combination of daratumumab either with Velcade or with lenalidomide or with pomalidomide, or isatuximab with pomalidomide, which is now available as 4th line, are certainly highly effective treatments. What's the next big thing which is coming? We've got 2 separate big things which are coming. One is these antibodies which can clear amyloid protein deposits. If KEL-101 or the NEO-001 shows benefit in clearing amyloid deposits, it will certainly transform the disease. We can clear these amyloid protein deposits rapidly, and organ function will improve very quickly. And the second thing is the active immunotherapy, which is the bispecific antibodies in the CAR T cells, which we think will be highly effective in amyloid patients because the plasma cells are not really malignant. They are generally sort of MGUS-like, fairly benign plasma cells, and immunotherapy has got a potential to have a high degree of activity in this disease. Still remains to be proven, but certainly that's my hope that if immunotherapy works, we may be able to transform this disease from a relapsing remitting disease to a disease that actually has very, very long-term remissions.
Yeah, that would be good news, wouldn't it? That'd be fabulous. I'd like to thank Kathy for sending in her question. So Kathy says, I have kappa light chain myeloma. Am I more likely to develop AL amyloidosis?
No, amyloidosis is more common for patients who have lambda light chain disease rather than kappa light chain disease. So about 2/3 of amyloid patients have kappa light chain disease, and then 1/3 have 2/3 have lambda light chain disease, 1/3 have kappa light chain disease. So people with kappa light chains are less likely to get amyloid than lambda, but amyloid can happen with either light chains.
Okay, thank you. We've also got a question saying, what advice would you give to patients in terms of diet?
The key for diet is sort of 2 or 3 things. There are a number of things we'll tell you that you can't have a lot of salt in your diet. Your fluid amount is restricted. So those 2 things limit what you can eat. Your taste may be affected because of the amyloid affecting your tongue or because of the chemotherapy that might limit what you would like to eat or what you might want to eat. And then the amyloid, which affects the gut and the heart involvement, may mean that having large meals is not that easy. And you may often have small meals or small frequent meals. So general advice is to have small meals, eat every couple of hours. Contrary to all the advice that the government gives, keep snacking all the time, and have foods which have got high calories. So things which will pack more calories in a small volume. And your dietitians could give you a list of such foods, typically those which are low in salt. So eating frequently, small amounts with high calories are quite important.
Lovely. So we've got a question from another Catherine. How do you become part of a drug trial, and how are the various drug trials faring?
So to be a part of the drug trial, every time you need treatment, please ask your team if any clinical trials are available. That sometimes allows you to access new drugs which may not be available for routine clinical care. The website of the National Amyloidosis Center usually lists the active clinical trials. The Myeloma UK website often has a list of clinical trials, and they often come in the various information leaflets. Or you're welcome to contact our team at the Amyloid Center at UCLH, where we always run all the trials that have open in amyloidosis. We'll be running them through our centers.
Thank you. And Margaret is asking about the side effects of dexamethasone affecting eyesight and swollen face. So her question is, at what point are alternative drugs considered if side effects are increasing? So
steroids are an integral part of all chemo regimens for amyloid and myeloma, for that matter. And all the steroids cause the same sort of side effects in terms of swelling of the face, sometimes weight gain, and occasionally affecting the eyesight. The solution is to often cut the doses down to the minimum dose that's necessary to keep the chemotherapy effective. And we sometimes use a steroid called prednisolone instead of dexamethasone, and that may cause less side effects. But these are difficult side effects as they are a part of the steroid activity, and we just have to manage and stop the steroids or reduce them as quickly as we can.
Okay, and a question from John. What can you tell us about mass spectrometry and typing? Is this carried out in the UK on a regular basis, and does it affect treatment? So
John, your question goes right back to the beginning, that amyloidosis is not just one disease, but it's many different diseases where proteins are abnormal and they can deposit into different organs. And therefore, when we do the biopsy, we have to confirm that the type of amyloid that you have is AL type, which requires chemotherapy. That's where mass spectrometry is required for typing the amyloid fibrils. We undertake it at the National Amyloidosis Center where it's required. We don't do it in every single case because we also use a technique called immunohistochemistry where we can use antibodies to detect amyloid deposits. And it is available in the UK for patients who need to have it.
Lovely, thank you. We've also got a question coming in from someone watching this on Facebook. Would you recommend maintenance therapy after a stem cell transplant? And if yes, what would you recommend?
So as yet, there are no clinical trials of maintenance treatment in amyloidosis. These have been done mainly in multiple myeloma. There is an overlap between amyloidosis and myeloma, and certainly for patients who are edging towards the myeloma range, there may be a role for maintenance as has been described for myeloma. It's important to remember that in amyloidosis, the tolerance for chemotherapy is very different, and therefore it's really important to ensure that if a maintenance regimen is considered, it is well tolerated and you don't have a lot of side effects. There is a lot of data that has been generated by our colleagues in Sloan Kettering in New York and in Boston, who have used short bursts of chemotherapy, what they call as consolidation chemotherapy with bortezomib or with lenalidomide following a transplant. And they've shown that patients who don't get a complete response to a transplant, it can certainly change the depth of response to a complete response. And my favor is to go towards having consolidation treatment for a fixed duration rather than very long-term maintenance. The only time where maintenance has been used is in the trial with daratumumab, where the treatment was continued for 2 years. And certainly there is good data to support that this is a really well-tolerated treatment as a maintenance following initial induction, which was recently reported in the Andromeda clinical trial. So patients who are on daratumumab, we will generally continue it as maintenance because that's what we've studied, and we are fairly confident that it is well tolerated. With the other drugs, it depends a bit on case-to-case basis.
Thank you. And it's rather apt that our final question from Maria is about COVID vaccines. So her question is, are COVID vaccines safe for AL amyloidosis patients, and will they be effective?
So we believe they would be safe in amyloidosis patients. We have no reason to believe that the reactions in amyloid patients would be any different to what's seen elsewhere, and generally most of the reactions appear to have been mild. We have certainly had a number of patients who have received the vaccine, and thus far we have not encountered any unexpected problems. Will they be effective is a very different question. That depends a little bit on where you are with your treatment regimen. If you're actively on chemotherapy, then all drugs and all vaccines tend not to be as effective. And will generally give you a short break from chemotherapy before and after the vaccine. But if you're in remission, then we do have a reasonable hope that the vaccine will work.
Thank you. So that's all the time we have for questions today. So would you like to move on to the next slide, Ashu?
How are we doing for time?
Yes, we're fine for time.
So far this talk has covered what is amyloidosis, how it can affect the body, how it is treated, how it is managed. And the three take-home messages here are it's a disease where there are excess light chains that are produced by plasma cells and misfolded light chains that bind together and deposit as tissues. Amyloid deposits cause symptoms because of organs which are not functioning, and these symptoms and complications need to be managed. Amyloid is treatable, both at new diagnosis or if the disease creeps back, but it is not yet curable and still continues to follow a relapsing remitting pattern. So long-term monitoring is absolutely crucial, and institution of treatment if the light chains come back is very important. And then we've got the Myeloma UK resource. I think we've pretty much come to the end. That's the last slide. Have I missed any slides?
No, that's great, thank you. So I think we've got some myeloma. Can you go back to the Myeloma UK slides, Ashu? I think there might be a slide before. Yeah, you can see on that one for now. That's lovely. So I'd just like to highlight some resources from Myeloma UK that you might find helpful. We have a series of videos that you can watch that explain some of the topics that have been mentioned today. Head along to the Myeloma UK website or YouTube channel to access them. We also have a series of info sheets that cover up-and-coming drugs and treatments that can be downloaded from our website. As we previously mentioned, we have our clinical trial finder and drug tracker if you want to find out more about trials taking place and drugs and treatments in development. And can you move on to the next slide, please, Ashu? Obviously, likewise, you can see here you can see our Myeloma UK info line number, and obviously there are AL amyloidosis support groups. And we, of course, in a normal space, we have our info days, and at the moment we have digital sessions, but hopefully ASHU will be welcoming you again to an in-person event at some point in the near future. So just finally, we've come to the end of the webinar today. So I'd like to thank you, ASHU, for speaking and answering questions. And I'd like to thank everyone who's joined us, both on Zoom and also on Facebook. And we hope that you found it helpful and informative. If we didn't manage to answer your question, or this has thrown up some new questions, please get in touch with us. You can do this via our info line or our Ask a Nurse email service, and details of those are on our website. Keep an eye on our social media and website for announcements of further Digital Infoday sessions. Once again, I'd like to thank you all for joining us this evening, and I hope you enjoy the rest of your night. Okay, take care. Thank you. Bye-bye.
Thank you, Suzanne.